we'll have to.
I have unmuted myself, but I
Yes,
am
sir.
on computer only.
Super.
If I am not seeing.
Yes, sir.
Hi, Bala.
Yes, sir. Yes, sir. Sir, what, sir? Good evening, sir. EMS, sir. Good evening.
Good evening, Bala.
So
Yes,
I
sir.
think so we are a little behind time.
Yes, sir. We'll start straight away, sir.
A small change in program. We'll have Dr. Balamurugan presenting
No,
first.
let people in. Let people in.
Yeah,
and then
just waiting
announce
for
this
people to
before.
join.
Yeah. Open the room, Smita.
Can I share my slides? Because that
Yes,
always creates a
Yes, sir.
problem.
I'm just opening them.
You need to make him.
There are almost 70 participants right now.
Yeah, I think we can start, sir. 70.
Please go ahead.
Yeah, so welcome everyone to this edition of the monthly CME series of the Neuro-Otology subsection of the Indian Academy of Neurology. This month we have two topics of two very interesting cases to be presented by a couple of experts in the field, Dr. Balamurugan from Salem and Dr. Ajay Kumar Vats from Udaipur. A small change in the program schedule. We'll have Dr. Balamurugan presenting first on his topic when migraine wears a vestibular mask. Sir, over to you, sir.
Yes, sir. Yes, sir. Thank you, Shini. Can I share my slides?
Yes, sir. Yes, sir.
The host is not allowing multiple presenters sharing for his webinar.
Yeah. Now we can do it, sir. The screen is now off.
Yeah. Are you able to see my slides?
Yeah, it's the.
Yeah.
It has entered, but it's not showing up.
Always it happens when I share that this happens, it's hung. It's totally.
You should remove the mask.
So you can stop and try again, sir. Probably it might work.
Hello.
Yeah, I think Sir has left the meeting. I think.
Yes, sir. Sir has left the meeting.
Just waiting for that. Okay. I think he's trying to join back in a lot of technical issues happening today. Okay. I think if it's taking long time, I think we will start off with Dr. Vats's talk. At least we don't want to delay people further. One second, let me just check with him. I'm just going to. So please go ahead, sir. Feel free to share the. Yeah, okay. Your screen is visible, sir. Please go ahead and share.
Sir, please unmute yourself.
Sir, you're on mute. Sir. Yes,
Yes,
sir. Now,
sir. Yes, sir. Good evening to you all. Can I give up, Sri?
sir, your
Sir, I can
presentation
see
is not. Yeah.
all your files here.
Slides
Just
is
click.
okay?
No, I can't see your presentation. I can see your all files here.
Sir, you're not on the. I don't think your PowerPoint is shared, sir. Your screen is shared, but only the folder is seen.
Just a minute.
So stop your sharing. You can open your presentation in PowerPoint mode first, then go to the Zoom and then share your screen.
Sure. Is it visible now?
Now it's better, sir.
Yes, it's
Yeah.
visible.
Thank you. Thank you. Sorry for the delay. There was
Yes.
some technical issues. Thanks, Indian Academy of Neurology, Neuro Otology Subsection, Dr. Srini, Dr. Vishal, and our Secretary, UMS, and the President, Dr. Ellen. So it's a great pleasure to share my talk with the senior person, the Neuro-Otology Authority of in India, Dr. Ajay Watts. I always call his presentation as not a Watts presentation, it's a 1,000 Watts presentation. So better I start my talk before his talk. So just introductory slides with that. You all know vestibular migraine is a chameleon of neurotology. A lot of articles during the episode of vestibular migraine has documented acute spontaneous vertigo lasting minutes to days, spontaneous horizontal and vertical nystagmus during the episode of the vertigo, and positional vertigo that could mimic BPPV, and persistent positional vertigo has been documented, especially like light cupola or apogeotropic also. Spontaneous horizontal nystagmus has been reported in nearly 19 to 25%, and positive bedside head impulse was reported in 15% of the cases. This was during ictal. Interictal, nearly about hundreds of articles, the interictal phase of vestibular migraine. So I'm not going into that aspect, but they have documented caloric asymmetry in 22% and abnormal video head impulse in 9%. And some of the neurologists say that when you have a discordance between hit and caloric, that's more likely of vestibular migraine. So these are the mechanism. I'm not going into theory. I'm going to show 4 cases as an emergency neurologist that I had come across over the last 1 year, which made me to come to this podium and share those cases and get the opinion and share the opinion of others too. This is 50-year-old woman, homemaker, present with acute attack of ongoing vertigo, associated with vomiting. During the attack, neck pain was there and she was avoiding moving the neck, a stiff neck. She gives history of chronic episodic headache during her 3rd and 4th decade of life. The headache was migraine in character. No specific treatment except of on and off paracetamol was given. During the attack of ongoing severe vertigo, she reached within 3 hours. So, at ER, this patient has ongoing vertigo of just 3 hours. So, window period. 50-year-old female. She had left horizontal with a torsional grade 3 nystagmus, head impulse abnormal on turning to the right, no skew, no ataxia, suggestive of, you all may agree that it's a peripheral acute vestibular syndrome. You could see during the attack, at the end of 3 hours, she reached. So, this was a left beating, and left beating, slight torsional component. And head impulse on turning to the right, catch-up circuit was there. So because this patient has reached within window period, acute vestibular syndrome, peripheral. So vestibular neuritis will be the logical diagnosis. But when looking at the history, she had previous history of classical migraine attacks over the last 10 years, and now presenting with first attack of ongoing vertigo. Now we are seeing at the end of 3 hours, this looks like a peripheral acute vestibular syndrome. So what is this? What is the likely diagnosis here now? Is it vestibular neuritis in a migrainer, or is something different? So let us ask perplexity for a change. So it gave the clue that it could be vestibular neuritis. Sudden severe neck pain with vertigo can indicate a vertebral artery dissection and vestibular migraine. 3 possibilities. This patient, because reached within 3 hours, so is it a pseudoneuritic type of stroke or something else? So MRI diffusion normal, MRA normal, it could be normal even in a stroke also. Received, so working diagnosis was probably vestibular neuritis versus migraine. So because one of the DD was vestibular migraine, vestibular neuritis, we gave methylpenicillin 500 mg with prochlorperazine. Then she slept well. Next day morning, she was totally asymptomatic and examination was normal. So next day, this is her bright morning day. So, and carefully see her head impulse. So some of you may agree that on turning to the right, some catch-ups are there. Even now also some, though she was not having nystagmus. So on turning to the right, it was slight catch-up was there. So she was asymptomatic, no symptoms. That means no signs also except this. So I asked again the perplexity, the same patient received solumetol, IV stemetil, and then what is the possibility? Now the possibility the perplexity gives is vestibular migraine more than the vestibular neuritis. The reason said was that the vestibular migraine attacks are typically episodic, lasting for 2 to 4 hours of duration, and symptomatic drugs such as stemetil can make markedly reduce the vertigo and nausea. And some of the patients can go for a spontaneous resolution over a short period, whether it's a spontaneous or whether it's a steroid, but short lasting and absolutely becoming normal. So this is the answer by the AI. So why vestibular migraine? The duration, shorter, and pre-existing history of migraine type headache, and this was a diagnosis. So why not others? Usually, more than 24 hours is vestibular neuritis. Within 6 hours is unusual. So this was the first patient. Second patient was more or less the same presentation. Migraine background, presenting with acute attack of vertigo, entering the ER within 3 hours. And you could see here, again left beating nystagmus, grade 3. The background voice says that obviously it is an emergency room. So the impulse, again on turning to the right, the catch-up circuit was there, but again neck stiffness. So one unique feature this patient had is a tight neck. So again, this was peripheral type, corrective circuits, all are for peripheral AVS. So this patient didn't receive steroid. I gave only prochlorperazine. So after about 2 hours, see that the symptoms came down, but still nystagmus was there. But it was not so severe. Again, grade 3 only, but it was not so severe in comparison to that. So this is again more or less same history. Ongoing vertigo with previous history of headache, and again within 4.5 hours. So window period, it was a peripheral vertigo as far as the hinge is concerned. So normal MRA, slept overnight. Next day, absolutely asymptomatic. I have not documented head impulse on the next day. So I asked ChatGPT. ChatGPT asked me money, so I didn't go with this perplexity this time. So because I used that day quota. So we'll go with case 3. This is a 54-year-old businessman. Again, to ER, he presents with acute vestibular syndrome of 1.5 hours duration, ongoing spinning vertigo, associated with vomiting. He had 2 similar episodes of acute vestibular syndrome in the last 2 years. Known hypertensive diabetic under control. No past history of headache, motion sickness, or migraine in the family. I was keep on asking the patient, because if there is a history of migraine, because with my experience of 2 earlier cases, if there is history of migraine, then I can put this is probably vestibular migraine presenting a senior vestibulopathy. When I was keeping asking given either uncle or maternal uncle, paternal uncle, and he was specially saying no, and then finally he said that, doctor, I'm sorry, none of my family members are having migraine. Next week I'll bring my neighbor who is having migraine, because you are very particular about the migraine. So that was the way that he answered politely. So on examination at ER, he had a right horizontal with torsional nystagmus of grade 3. Head impulse test is for your perusal, and no skew deviation, grade 1 ataxia, and it was suggestive of head impulse is like sometimes we get a plantar equivocal. So when I asked my colleagues, 50% said that head impulse is normal, 50% said that abnormal. So for me, it appears as normal only. It was a nystagmus. It was a right beating rather than the head impulse. So here it is only thing that head impulse is normal, but you could see here the right beating nystagmus, grade 3. Yeah, fine. So is he able to walk? I can put if at all grade 1 ataxia. So this is I'm for normal head impulse in that patient. So this looks like a central. When head impulse is normal, that it should be central. So this is MRI was absolutely normal, and to our surprise, when he came back from the MRI, he was absolutely normal, no signs, no symptoms. So when I asked what happened in MRI, any injection was given, he said, no, I slept. I'm tired with vertigo and vomiting. I slept in the MRI. So with the background sound, he could sleep in the MRI. It was surprising, but he slept and then he got up and then he said, normal, I'm normal. And he said that the previous episode is also more or less same. This episode he asked for an MRI. Previous episodes, some doctor gave some tablet and I slept and then it's normal. So this time your team activated code stroke, everything, but that's the only comment by the patient. So he was certainly normal, no ataxia, and he could stand with eyes closed. So here again, reaching within window period of acute ongoing vertigo. So that is more in favor of now central because head impulses is normal here and no past history of headache, but had previous history of 2 episodes of similar vertigo. Both of them also lasted few hours. So with normal head impulse, a central type of things, I have to vote for a stroke. So now the patient has recovered. Now the question comes whether he had a TIA or is it again vestibular migraine. So the A gave the answer. It could be recurrent vestibular neuritis. 3 episodes. All episode lasted for 3 to 6 hours. I don't agree with the diagnosis, but it could be vestibular migraine or could it be TIA what the person is having. 2 years, 3 TIAs, all recorded within 4 hours. All the patient had only vertigo and his vascular structures, this MRE was normal. And later we did angio also, which was also normal. So the third case is a little bit tricky in terms of not the true peripheral variety, it is a central because of the head impulse. The last patient, 40-year-old male present with episodic vertigo of 1 year duration. Each attack lasts for about 2 to 5 minutes, once in 2 to 3 months. All the attacks associated with headache, neck pain, and nausea. The headache lasts for about hours to days, but the vertigo is just 5 minutes. During the attack, he has to be quiet and avoid seeing light, hearing noises. During the headache period, he gets this vertigo. So when I examined, it's totally normal. So because he came in between the attack, so interictal phase. So I asked him, better you go home when you get the attack, you ask somebody to record the event. So somebody can record. So he came back and telling the story, and then when I examined it, it was absolutely normal, no nystagmus. So what happened? This was a picture, headache, vertigo. During the episodes of headache, some of the vertigo, this is more likely. So one episode he had after my consultation, he had at home. So he asked his daughter to record, and you could see at home video recording. He was having headache nearly about 2 hours before this particular vertigo event. Having headache 2 hours, then having vertigo, and asked her daughter to record. See, so daughter is telling that in the background, your eyes are moving. Involuntarily you are moving. Are you moving or the eyes are moving? So he said, no, my eyes are moving. This is what doctor asked me to record. Continue record. It lasted for about, the video lasted about 2 minutes. And he said that I gave prochlorperazine sublingual, that means mouth dissolving. He took that, but he said that doctor was solved within 5 minutes as usual. So during that phase, because nobody could do the head impulse, so whether I could train the daughter doing the head impulse, I don't know. So this during the headache, the patient had a vertigo just for minutes and then nausea. So to summarize these 4 patients, patient 1 and 2 is classical of peripheral acute vestibular syndrome. All head impulse, the type of the nystagmus, favors, and 1 and 2 had a past history of migraine. So the lasting for about 6 to 8 hours. The patient 1 received methylprednisolone and Stemetil. The patient 2 didn't receive methylprednisolone, only Stemetil. Third case I was A little bit worried about whether I'm dealing with the TIA because this head impulse is normal, but again lasted for 4 hours and recovered completely. No history of migraine at all, but had recurrent episodes of vertigo. And the fourth last one, at home video, I can't comment about the periphery or center because nobody has done the other skew deviation, other things, but again, few minutes. So history wise, the fourth case fits into vestibular migraine. Only third is difficult, but one unique feature is all the patients had unilateral vestibular pathology, acute. Now, we all know about acute vestibular syndrome coming to our emergency, ongoing vertigo or acute prolonged vertigo. The definition of acute vestibular syndrome is lasting more than 24 hours. But for a practicing emergency neurologist, they reach within the window period. So we have trained our people to reach to the emergency neurology whenever you have a balance problem or eye problem. So we have trained that much, so they reach within 4 hours. Now the problem comes at ER, ongoing vertigo. I can't say it's a transient, it's going to end by 6 hours or it's going to prolong. That's my difficulty. And I can't do VNG or calorie test then because it lasts short lasting 4 to 6 hours. And with the severe neck pain in the 2 patients and then vomiting, difficult cooperation is also needed. And we don't have 24 hours lab of VNG. Maybe video hit may help in these patients. So I don't have video hit portable. So if no past history of headache, if there is past history of headache, fine. These 2 patients, the initial 2 patients. If there is past history of vertigo, fine. This won't come as acute. This will come as the episodic vertigos. That's different DDs. The hints is mostly periphery in this case, but 1 patient had a central because head impulse was normal. So my thought process was that acute vestibular syndrome, rather than the prolonged, if you have a transient at the end of 6 hours. So before 6 hours, what you call that? It's ongoing only. If you had seen the patient at the end of 6 or 8 hours and recovered completely, vestibular migraine, especially if it is recurrent. So 2 of my patients had a recurrent migraine and 1 patient had recurrent vertigo, not migraine. So the best, but at the same time, a dangerous differential is TIA when you have a head impulse that we all know. When we are not able to examine the patient during the ictal phase, maybe video recording is very simple and best that gives the idea of what they are having. I personally feel these patients are not vestibular neuritis because of short lasting. At TR, ongoing vertigo, reaching within window period. That's a problem for emergency neurologist. Objective reality versus subjective perspectives. It's very easy to put all your hints in a slide, but we are standing here at the end of 4 hours, patient reaching to ER with ongoing vertigo. Whether it's going to be a prolonged or transient, I don't know. I am standing here. In that situation, if there's a past history of headache in 3rd or 4th decade, if they are coming, fine, I'm comfortable. Again, 3rd and 4th decade, past history of vertigo is also there. Okay, but after 50 vertigo, past history of vertigo alone, no headache. So especially when head impulse is central, I have difficulties in saying with certainty versus migraine versus TIA. Of course, I have to go with the ABCD score in a high-risk individuals. These same patients coming to me with recurrent episodes of vertigo, I may go for TIA rather than vestibular migraine. So I think I'm not going to talk much about the theory. So this is open for discussion, all the 4 cases. Thank you. Thank you all. Hello.
Thank you, sir. Thank you, sir. That was a fantastic talk. Very, very interesting, all the 4 cases. Just one question about the 3rd case that I had. You said you consider TIA as a possibility. If the symptoms are not abated, would you have still thrombolysis with a negative MRI?
Yes, definitely. Yeah, because even if it is a mimic, thrombolysis is not going to harm the patient. Okay. So I asked for an MRI, by the time the patient came, so the patient recovered. So I have to consider as a TAA. So if the patient had come to me within 2 hours, after a month also having the attack, at the end of 3 hours, I would have done thrombolysis because head impulse is normal.
Okay. And another question, mine for the fourth case, you mentioned that they were very short attacks that he had.
Yeah.
Does using any abortive medication actually work? Because any medicine you give is going to take some time to actually kick in. The blocoperazine.
I don't know this because this patient was just by the time they take the tablet, he said that, but probably the migraine that which was suffering, because the last case, during the episode of headache, he had that vertigo. So probably that would have aborted it, at least at the headache.
Yes, sir. Yes, sir. Just waiting to see if there are any questions from the participants. We have more than 100 attendees.
Yes, sir. Any comments or any other? I'm following these patients intractally. I have not presented that intractal vein NGVs. I have not presented purposefully. I'm following these patients. So to get that long-term follow-up, what are they actually? Especially, I'm much interested in the third case where I had a normal head impulse and still I'm not clear as a TAA or not.
And I had a very similar patient who I had initially labeled as a TIA.
Okay.
Who came with acute vertigo with multiple risk factors. So to labeled as TIA, came in with vertigo, resolved overnight. Seen her in ER, next morning she was normal. MRI negative, said okay, probably TIA. And then she had another attack the next day while I was doing my rounds. Clinically evaluated, and then that was very suggestive of vestibular migraine. Then the diagnosis changed. And I think somehow she ended up with another neurologist when she had another attack. And they did a BNG and they labeled it as BPPV. And then she kept having these attacks triggered whenever she had any migraine risk factor. I mean, a lack of sleep or stress, that she ended up having these attacks. And then we put her on multiple drugs for managing the migraine. So
Yes,
I think
there's a combination of migraine, vestibular migraine, and BPPV. Sometimes we see both in the same patients. Not sometimes, commonly. So
you do see
because
this pseudo BPPV patterns. I think that can confuse us sometimes with the history, especially with the positional worsening. I think there's a question which has come in. How much patient of positive hit can later turn out as a PCA stroke?
So positive hit has to be considered as a stroke only for all practical purpose. But the question is that this patient,
I think that's positive hit as in positive hit catch-up saccade.
So positive hit means that so that's because this question is that when you have a peripheral type, that's a question that when you have a hit is peripheral type, pure neurotic type cannot be ruled out. So if you have some clue in terms of grade 2, grade 3 ataxia, acute onset hearing loss, then we can go for that. Otherwise, this is a border zone where a pure neurotic type, when the fascicle is involved, that means the brainstem particle before reaching the nuclei, that part is involved, that can mimic like a pure neurotic. What I call is a nerve stroke. So rather than the brain stroke, we call it a nerve stroke. So
yes, sir. Somebody's also asked, in all cases, you may not get positive hit. Can we still consider for vestibular neuritis?
Vestibular neuritis, no catch-up circuits. Am I right? Is the question that they are asking. Vestibular neuritis not having catch-up circuit. Is the question they are?
Yes, sir. That's what they have asked.
Okay. Vestibular neuritis, no catch-up circuit in the acute phase. I have not seen, sir.
So this is you're on mute, sir.
Unless, yes, sir. Vestibular neuritis, no catch-up circuit during the acute phase. I have not come across. I leave it to the open for the discussion. That particular question is very interesting.
No, you cannot diagnose vestibular neuritis if head impulse test is negative.
Yeah.
It has to be abnormal.
Unless it's a bilateral, I mean, even if bilateral, it should be positive.
Bilateral, it will be bilaterally positive.
Bilaterally positive, yes, sir. Yes, sir. Now, also another
and I mean, the very interesting case is Dr. Balmurugan.
Thank you, sir.
We have found patients coming to the casualty and getting admitted for acute onset vertigo, and you don't find the head impulse positive, and then we are left wondering that all this is looking central, but the MRI is normal. So of course you can have MRI normal for the first 72 hours, and then we have had such patients. We repeat an MRI at 72 hours, and it is still normal. Patient improves over the next 12-24 hours, and it was actually migraine. And of course, when you dig deeper, most people will have a history of migraine in the past. So it is there. So therefore, when somebody comes with acute onset vertigo and imbalance, it can be migraine. You very nicely highlighted that. Regarding head impulse, I have a little different take. I don't accept that head impulse is positive in migraine. Usually it's not. If head impulse is positive in a patient with acute onset vertigo and this sort of nystagmus, I would think of Meniere's. In Meniere's, you can get the labyrinth abnormal. It's a peripheral disorder. In migraine, it is a central disorder, so head impulse should not be abnormal. You can get catch-up saccades. A lot of studies have shown that you can get saccades in migraine, but the head impulse will be negative. The VOR, when you do the video head impulse test, it will be normal. And I'll post that in the group later on sometime, the review that if you find a person with definite head impulse positive in an acute vertigo, think of Meniere's or labyrinthitis. Of course, your patient improved within 24 hours, so it could not be labyrinthitis or vestibular neuritis. So it must have been
They
either
improved within 6 hours.
migraine
Can I interrupt, SK?
Yes, please.
Yeah. See, the point that you made is very right, but with the caveat that acute vertigo plus a positive head impulse need not always mean peripheral. It can occur with an ICA syndrome.
It can,
Yes.
absolutely. And
And
therefore
so
the head
where the
hints,
fibers come into the
therefore the hints is not just head impulse. The hints
important,
is head
yeah.
impulse,
Yes, yes.
test of skew, and
Correct.
this. You have to do all.
So you
You
don't
have to do all.
correct. But so this caveat should be remembered. But then this migraine and Meniere's is always, especially if the patient gives a history of migraine, the both of them last about the same time. The vertigo lasts the same time. I'm one who goes by the history more and more, and I think about what triggers and how long it lasts. I think that to me is the key for approaching vertigo. And that sense that migraine and Meniere's, it has a very complex relationship. People with
Yes.
migraine are prone to Meniere's. People with Meniere's are prone for migraine. So
Yes.
sometimes it does coexist, but it's very difficult to make it. Sometimes it happens that you have to treat for both in a patient, and you don't know which is
You
working.
cannot see the only difference between Meniere's and migraine is progressive hearing loss. If you show progressive unilateral hearing loss, that is Meniere's. In migraine, you will not get progressive.
No,
But a patient of migraine says
I
during an
agree.
attack, I can't hear.
I agree. The sine qua non is hearing loss and the response, but sometimes it does happen that this patient has this hearing loss, but also has a history of migraine in between. So they coexist. They are, and in that sense, sometimes,
Yes,
and
yes,
the drug
very
that
important.
really comes to our help is topiramate, because it sort of helps in both conditions.
I won't go by that. See, the thing is, topiramate or any drug where when you treat migraine, you'll have a very high placebo response. In Meniere's also there is you can't tell what is happening. If you have there is no reason why somebody with a hearing loss, let's say due to otosclerosis or some old hearing problem, gets migraine also. He can get, but it will not be a progressive hearing loss.
That's what I said. Sometimes you do not know because they keep getting the headaches too, and because the
Yes.
vertigo lasts very similar, you would rather treat
You cannot
both.
distinguish. There
You
are
cannot
so many
distinguish.
articles which say you cannot distinguish,
Cannot
and there are
distinguish
lots
matter.
of tests. People try to do this test, WEMP, do that, do whatever,
Correct.
cochleogram. No
Ultimately,
test
it's
can
all your
tell.
clinical thing. Yeah.
No test can tell.
Correct.
So there's one question which has come. In inferior vestibular neuritis, can horizontal head impulse can be normal? Can we take it as, can we still use that?
Yes, sir. Inferior vestibular neuritis because it involves the posterior canal. So horizontal may be normal, but when you look at isolated inferior vestibular neuritis, the whole percentage is less than 2%. I remember as. So very rare it can be. That is one caveat as vestibular neuritis having a normal head impulse. So that's one thing that where you can have when you do a horizontal head impulse. When you go weak with posterior canal, then that will be abnormal.
So I think, I mean, another question is about the vestibular
Again,
migraine.
this
Yes.
thrombolysis question, I think you should take up because the
Mhm.
people are worried that what if you don't thrombolize a posterior fossa stroke? I think you have to be very careful. You don't want to thrombolize a migraine. You don't want to thrombolize a Meniere's. You must do the Hintz protocol properly. And if you are convinced that the Hintz is negative and the patient should not be able to stand, use the standing test. The patient should not be able to stand or walk without support. A vestibular neuritis will be able to stand without support. He'll be able to walk without support. A cerebellar stroke will not be. So only a stroke who is not able to stand or walk, you thrombolize.
I think the next
I
is
think this
the question
message is
there.
very convey the Professor Sudhir Kothari sir, because in vestibular migraine, it can mimic like a central because of as you rightly said that. But in the situation, I teach my residents rather than going for head impulse, first go for ataxia. When the ataxia is grade 3, go for stroke. Because head impulse is very difficult to train the residents. And looking at the Instagram is also very difficult. So when you have the take of less than 4.5 hours, just go to ataxia. Very easy. So not able to sit, not able to stand, go to ataxia. Come from ataxia to head impulse. That point is again as we stress to the resident. It's a well said because vestibular migraine can have a normal head impulse during that attack, but they can mimic like a peripheral vestibular neuritis in terms of their nystagmus. So that's one good mimic. But none of my patients of vestibular migraine had grade 2 ataxia. None had a grade 2 or grade 3 ataxia. So that is a strong clue when you are contemplating between these two things. But when they come at the age of the third case, when I said that 2 attacks of vertigo and having vascular risk factors are hypertension and diabetes, and that is the situations where we are really contemplating doing TAEs and this. Thank you, sir. Thank you for the
I think even Ajay, once if he's online, he has had a recent. He's reviewed this acute vestibular syndrome stroke thing very well. Like you pointed out, the grade 3 ataxia is very useful. When a houseman calls me up, I don't want to rely on his interpretation of the head impulse. Of course, I ask them to take a video and send it, but thrombolizing on the basis of that video, I ask them, can the patient stand or walk? If he can't stand, no.
You can change rather than hit hints, we can change as A hints. A for ataxia, then go with hints.
But all said and done, I think we'll also agree that isolated vertigo, years ago there used to be this in Kaplan's monologue that isolated vertigo is never stroke, but we do know that it can now. We know that it can happen especially with the posterior vermis lesion. But the isolated vertigo is a rarity. It's usually about what is associated. I agree with SK Sudhir that these patients cannot stand or walk. And that's something that I'll ask the ER physician always when they call me. Can this patient, if they say, no, sir, the patient went to the restroom and came back, I'm very happy. I'm saying that, okay, this is not a stroke. Don't worry about it. Don't rush. It's not a problem. But they say that needs assistance, I would be very wary of it. But then it's always about looking for the other signs. I think there are a lot of comments from Dr. Jacob in your thing.
I think there's a question about the dissociation in vestibular migraine and Meniere's between the caloric and the head impulse test dissociation. I think Dr. Jacob has mentioned about how vestibular dysfunction affects low frequency. So Meniere's affects low frequency, hence caloric will be abnormal, but not HIT, which is high frequency function. Is there any comment on that, sir?
So some of the paper, anybody took some of the papers has emphasized too much about this difference between caloric will be abnormal when you have a dissociation between the head impulse and then caloric. That's more in favor of migraine. So, but I have not done any caloric in the emergency room. So to say that because it's very difficult to do the caloric test in the emergency room. When they come in between the attacks, it may be useful. But there's a practical difficulty what I focus today when they are coming within 4 hours when you are in ER doing these tests. So I agree, the caloric test, but again, the authors highly variable. That the first slide I quoted, that the caloric response is abnormal even in migraine also, and head impulse is abnormal even in migraine. So it depends upon
Those I don't agree with that. Huh? Those reviews those are old. The newer
Yes,
reviews
it is.
say that they've
So
done video head impulse. They've done a lot of studies. I will post that in the group later on. It is rare. You should be you should be surprised if you find head impulse abnormal in migraine, and you should look for something else. Um, I think that has to go. But
Thank you,
when
sir.
we
people
totally
should not
agree,
normalize.
And I should
so
also remember
one
that
comment is, when we totally agree that we are going with migraine is only central. So it's
we
not
should
only
also,
central.
we should also remember that migraine with aura is a risk factor for stroke.
Right.
And somebody is asking, at age 70, can you get migraine, vestibular migraine? In fact, with
Yes.
age, headache becomes less prominent
Yes,
and you get
only
all these other
vertigo.
symptoms.
Yes.
Vertigo will be more common.
That
They
is
would
a
have, yeah,
that is a
it's very
difficult
likely, especially in older women, that they have migraine in their 40s and 50s, but in their 60s, 70s, they have pure vertigo, no headache. That's known to occur.
that is a different entity called epigon migraine vertigo, EMV.
Correct. Correct.
Yes.
I think in the interest of time, I'll have to cut short this fascinating discussion right now. We'll move on to the next case. Thank you, Dr. Palam.
Thank you. Srini. Thank you all for wonderful
Thank you.
contributions.
The
Thank you.
most important thing, Dr. Balmurugan, the first slide was very important. It is a chameleon. It can mimic any syndrome. So people have been writing here, we have not seen acute vestibular syndrome. You will see acute vestibular syndrome due to migraine. You'll see BPPV due to migraine. You'll see everything due to migraine. It is a chameleon. Thank you.
I think we'll move on to Dr. Vats's talk. Dr. Ajay Vats needs no introduction. He's one of the pioneers in management of complex BPPV. And today, sir has agreed to talk to us about one of the rarer varieties. We'll go ahead with the talk. Thank you, sir. Please go ahead.
Good evening. The topic for today's talk is short-arm posterior semicircular canal BPPV variants. The expanding realm of our understanding about this newly known variant. The short arm of the posterior semicircular canal. The utricular macula you see here lies in a depression called the elliptical fossa in the bony labyrinth. Here the utricular macula has a gelatinous matrix in which the otogonal debris is normally embedded as calcium particles. This is the short arm painted in the red. The otogonal debris can detach from the utricular macula and directly drop into the short arm, and this was once upon a time used to be called type 2 BPPV or subjective BPPV by the Buki et al. As early as 2011. However, it can drop directly and get adherent to the short arm side of the posterior cupula, leading to short arm side posterior semicircular cupulolithiasis. So, how does the typical posterior semicircular canal BPPV occurs? The commonest variant, which is the Gardner variety, the typical periampullar variant, is believed to be caused by dropping of the otogonal debris from the utricular macula near the periampullar region. So, how it is treated? By the Epley maneuver or the Simond maneuver. So, what goes wrong in patients who have residual dizziness, especially the setting of vertigo? The possible pathogenesis of short-arm posterior semicircular canal canalolithiasis is that when we treat the typical periampullary posterior semicircular canalolithiasis with the Epley or Simond maneuver, the otogonal debris slips off from the utricular macula and reaches the short arm. And that's how the early retests are usually associated with the short arm posterior semicircular canalolithiasis, and in these patients with residual dizziness, the sitting of vertigo with truncal retropulsion is a common finding and a non-positional disequilibrium even while walking. A short review of literature is being made here on the short arm posterior semicircular canal BPPV. In year 2001, O's found that Dix-Hallpike test cannot differentiate between the long arm and the short arm posterior semicircular canalolithiasis. However, the absence of reversal nystagmus on sitting from the Dix-Hallpike testing, absence of the orthotropic nystagmus or the presence of downbeat nystagmus during the second step of the Eppler maneuver was suggestive of short arm semicircular canalolithiasis. Buki in 2011 found that in certain patients, vertigo spells occurred during and after sitting up. There was associated anteroposterior truncal retropulsion. It was treated with multiple sit-ups from the lateralized Dix-Hallpike position. Tora 2011 found that Dix-Hallpike test is like typical BPPV, but it is persistent, lasting more than 60 seconds. There was no reversal nystagmus. It was unresponsive to Eppler maneuver and responded to temporal bone vibrations in the lateral recumbent with the involved ear up. Scocco in 2022 found sitting of vertigo, upbeating ipsitorsional nystagmus on sitting from Dix-Hallpike test, persistent upbeating ipsitorsional nystagmus during the half Dix-Hallpike testing, and in 11 out of 18 patients there was ipsicanal cupulolithiasis was present. Ping made an interesting study in 171 patients which was supposed to have typical posterior semicircular canalolithiasis. In 40 out of 171 patients, they did a bow and maneuver alone and it responded. The rest responded to the Eppler maneuver. In our own study, we found that in 9 patients, 2 only had posterior semicircular canalolithiasis of the short arm type. 4 out of 9 only had posterior semicircular cupulolithiasis. In 2 out of 9, posterior semicircular cupulolithiasis probably coexisted with cupulolithiasis, and in 1 out of 9, possibly the long arm was presented with the short arm posterior semicircular canalolithiasis. Halmensky 2024 found that short arm posterior semicircular canalolithiasis was similar to this series of Scocco and our series. However, they coined a term short arm side posterior semicircular cupulolithiasis, where they found downbeating contratorsional nystagmus during the Dix-Hallpike testing, and this is a relatively new finding. They are speaking about downbeat nystagmus during the Dix-Hallpike testing. So, first 3 cases, 1, 2, and 3, they are cases of residual dizziness in a patient with right typical posterior semicircular canal BPPV, treated with Eppler maneuver. The third patient was treated elsewhere. Case 1, she is a 49-year-old female, came with the history of positional vertigo on day 1. So the typical upbeating right rostral positional nystagmus of less than 1 minute, it was hardly 15 to 20 seconds. She was treated with the Eppler maneuver. On day 2, after 24 hours, the right Dix-Hallpike test during 1 minute of observation did not elicit any nystagmus. Fast forwarding it to 30 seconds, no nystagmus, 54 seconds, no nystagmus. We maintained the right Dix-Hallpike head hanging position for full 75 seconds. Still there was no nystagmus. So what to do next? The next thing we do in our clinic is to anti-flex the neck 60 degrees from the current position. So anti-flexing the neck 60 degrees resulted in elicitation of right torsional upbeating positional nystagmus. She also had a concomitant vertigo while being tested during this position. This was a persistent nystagmus lasting for more than a minute. So in such situations, it could be a short-arm posterior semicircular canalolithiasis or cupulolithiasis of the right posterior semicircular canal. And in all such cases, we have learned by the experience that from here, the current right half Dix-Hallpike test, the inversion test should be done. If the nystagmus disappears during the inversion positioning, that is lateral recumbent to the non-involved side with nose down, then it is a short arm, and if it reverses direction, it is likely to be the posterior semicircular cupulolithiasis. The nystagmus is still continuing during the uprighting from the right Dix-Hallpike position. So we treated this patient with the prone, pitch, and yaw maneuver, which is an adaptation of the bow and yaw maneuver, first innovated by Ping et al. From South China. They published their study in the Brazilian Journal of Otology. The prone, pitch, and yaw maneuver is shown here. With the head taken out of the short edge of the examination table, the clip speed is twice. It is around 3 cycles side to side, 30-degree excursions for 1 minute. And after 1 minute, the head is placed in this position for another 1 minute. The reason being that short arm of the posterior semicircular canal is a narrow tract. Here it is quite possible that the otoconia may be partially jammed or may be stuck to the inner wall of the tract. So thus shaking the head side to side for a 1 minute moves the otoconia towards the utricle, and another 1 minute static positioning is done so that it gets time to embed into the utricular macula, its gelatinous matrix. If you keep on shaking the head without maintaining the static positioning, it won't get fixed into the utricular macula. Case 2 is a female, around 52-year-old. She came with 4 days history of vertigo. The right Dix-Hallpike test shows upbeating right torsional positional nystagmus. It was decided to carry out a right apply maneuver there and then only. So this is the diagnostic Dix-Hallpike testing, and we made it the first step of the apply maneuver. So after 1 minute, the positioning to the other side, that is inclining the head 90 degrees to the non-involved left side, was done. Here also you got a orthotropic nystagmus, which is beating up and the torsional component is towards the involved right side. This is the position 3 of the apply maneuver with nose down. Here in fact no nystagmus is seen. Ideally, if everything is going well, the orthotropic nystagmus should also be seen in the position 3 as well as the position 4 as the patient gets up to sitting after the third position. So we completed this apply maneuver then and there only. The patient returns next day with sitting of vertigo. The Dix-Hallpike test is negative. There is no nystagmus during the right dick sulpike head hanging position during 1 minute of observation. So what did we do? We looked the oculomotor responses on sitting up from the right dick sulpike testing. And now you clearly see an upbeating right torsional positional nystagmus. So what is happening to this patient? One possibility is that the short arm posterior semicircular canalolithiasis of the right side was coexisting with this patient, or it got the intracannular migration from the long arm to the short arm occur because the otoconal debris did not get embedded into the utricular macula. So we did a half dick sulpike test. This was earlier as I used to do it, supporting the head and antiflexing it 30 degrees above the horizon. So this was maintained for around 97 seconds. The nystagmus still continues. So after 97 seconds, left lateral recumbent with nose down was done. The nystagmus now disappears. So why the inversion test is negative during the half dick sulpike testing and the inversion testing? This is the sitting. During the half dick sulpike test, there is a ampulofugal deflection of the right posterior cupula, resulting in upbeating right torsional positional nystagmus. On inversion positioning, that is the left lateral recumbent with nose down, the otoconal debris falls away to the short arm and there is no cupular deflection. That's why the nystagmus disappears. Case 3 is a female around 47-year-old. The right dick sulpike test during 1 minute of observation did not elicit any nystagmus. So antiflexion of the neck, that is the cervical spine, from the current right dick sulpike position was done. And it now elicits right torsional upbeating positional nystagmus. As you see now. She was treated with prone pitch and yaw maneuver, and she responded in less than 24 hours. She had been treated for the right apple maneuver elsewhere about 15 days back, but was experiencing sitting up vertigo and truncal retropulsion on getting up from supine. Case 3 is a 52-year-old female, came with the positionally triggered disease spells for 15 days. The left dick sulpike test shows upbeating left torsional persistent nystagmus. Persistent means lasting more than 60 seconds. So what to do when it lasts for more than 60 seconds? It is a dick sulpike position, not the half dick sulpike position. So in any case, the threshold limit for our observation is 60 seconds. At 60 seconds, the inversion test is required to be done. In this case, positioning the patient right lateral recumbent with nose down. If the nystagmus disappears, then it is likely to be the short arm posterior semicircular canalolithiasis, and if it reverses polarity and becomes downbeating and right torsional, it is likely to be cupulolithiasis. However, during the inversion positioning, the nystagmus disappear. From the current inversion position, we repositioned her back to the left disc sulfide position to look for the effect on the nystagmus, whether it reappears or not. So it reappears. So it is likely to be the cupule, short arm posterior semicircular canalolisthesis of the left side. There was an upbeating left torsional positional nystagmus as the patient was uprighted from the left disc sulfide position. However, such a finding is not very useful in distinguishing between the two conditions. Such a nystagmus that is upbeating torsional on getting up from the disc sulfide position can occur in both short arm as well as canalolisthesis as well as the cupulolisthesis of the posterior semicircular canal. We treated with the bascule maneuver, and after 3 days of continuous bascule maneuver, she had a typical crescendo decrescendo short lasting nystagmus of around 20 to 25 seconds duration, suggestive of transformation to the typical periampullary variant. So how did the bascule maneuver work in this patient is shown by this diagram. You see the red circles as I move them here. It is the otoconia in the short arm. Possibly they are not adherent. In the nose down position, that is the first position of the bascule, they move towards the common crus. And the next position, that is the reverse Simon positioning, they move towards the lowermost part of the long arm. And the getting up again, they reach the periampullary region. Case 5 is a 62-year-old female, a gynecologist doctor. She very kindly allowed me to show this case here. She was treated for the left typical periampullary posterior semicircular canalolisthesis a day earlier. Now she returns with dizziness, both positioning to left lateral recumbent as well as on getting out of bed, that is getting up from the supine. The left disc sulfide test during 1 minute of observation did not elicit any nystagmus. Fast forwarding it to 30 seconds, no nystagmus. 45 seconds, no nystagmus. Full 1 minute, no nystagmus. So again, following our protocol, we anti-flex the cervical spine 60 degrees from the current left disc sulfide head hanging position and look for the nystagmus. And you can now see a very strong left torsional upbeating positional nystagmus. That was persistent, lasting more than 60 seconds. So next thing to be done in this case was the inversion test. That is, transitioning her to the right lateral recumbent with nose down. Inversion test is being shown here. The inversion positioning shows transformation of the nystagmus to downbeating and right torsional. The upper corneal poles of both eyes are torsionally beating to the patient's right. So what has happened to this patient? The patient was treated with the Applet maneuver a day earlier by me. The otoconia, they, instead of getting embedded into the utricular macula, reached the short arm side and possibly got adherent to the short arm side of the left posterior cupula. So we again treated her with the bascule maneuver. The augmented Dix-Salpike test was done 4 hours after the bascule maneuver. This again shows a left torsional upbeating nystagmus, though it is less intense than it was seen in the morning. In any case, the inversion test was necessary to make it sure that are we dealing still with the cupulolithiasis of the left posterior semicircular canal. She was again transitioned to right lateral recumbent with nose down. And now, during the inversion positioning, there is no nystagmus. So the cupulolithiasis on the short arm side of the left posterior cupula after bascule maneuver becomes canalolithiasis. The inertial forces that were generated during the bascule maneuver, they disengage the otoconal debris from the short arm side of the left posterior cupula. This is being shown here by this animation. Case 6 is a patient with persistent upbeating ipsitorsional nystagmus with positive inversion test. A lady around 48 years old. The right half Dix-Salpike test. The head lands on a 4-inch thick pillow. Shows a persistent right torsional upbeating positional nystagmus, and this is quite robust. As you can see now, it lasted for almost 2 minutes, so I am fast forwarding it to 2 minutes here. At 2 minutes, we carried out the inversion test. The inversion test is positive. The nystagmus becomes downbeating and left torsional, though it is not as robust as it was seen in the right half Dix-Salpike positioning. The upper corneal poles of the eyes are torsionally beating to the patient's left, and there is a clear-cut vertical downbeat component. This grade of the inversion test, we call it as mildly positive inversion test. We also did a Dix-Salpike test in this patient to make it sure. This is the Dix-Salpike test, again shows a persistent nystagmus which is upbeating, and it lasted for more than a minute. fast forwarding it to 1 minute. When we decided to upright the patient and look for the nystagmus on uprighting from the right dicksulpike position. Now again, we observe a upbeating and right torsional nystagmus. However, such a finding, that is uprighting the patient from the right dicksulpike position, and we get a upbeating ipsitorsional nystagmus, does not distinguish between the posterior cupulolithiasis and short arm posterior semicircular canal lithiasis. At that time, the bascule maneuver was not known. This is a 2023 patient. We treated her with the Brand-Daroff exercises and she responded over a period of 1 month. So inversion test in heavy graviceptive cupula. This is the heavy graviceptive cupula because of the adherent type of cupulolithiasis. The amphilofugal and amphilopedal cupular deflections in the half dicksulpike testing and the inversion testing are equally strong. So the inversion test is strongly positive. In short-arm posterior semicircular canal lithiasis, the otoconia fall away from the short arm of the posterior semicircular canal, and there is no pupillar deflection, so it is called negative. However, when the short-arm posterior semicircular cupulolithiasis coexist with short-arm posterior semicircular canal lithiasis, the part of the otoconal debris is offloaded from the short-arm side of the posterior cupula, and that's why the inversion test during the inversion positioning, amphilopedal deflection is not all that strong. This is all our hypothesis. Case 7 is an interesting patient. She's a lady, 37-year-old. She came with the history of positionally triggered disease spells. The left dicksulpike test, half dicksulpike test, shows a nystagmus after a prolonged latency of 45 seconds. So fast forwarding it to 40 seconds, and now at 45 seconds you will see a nystagmus. Which is upbeating, and the upper poles of both eyes are torsionally beating to the patient's left. So again, the critical threshold of persistence, that is, this nystagmus lasted for more than a minute. So what to do next is inversion testing, that is right lateral recommend with nose down. Here the half dicksulpike test was done by landing the patient's occiput on a 4 to 5 inch thick pillow when the head was yawed to the left in the upright sitting position. So it gets anti-flex 30 degrees. Now right lateral recommend with nose down. We remove the pillow and the nystagmus disappears. Hardly any nystagmus. We observed for a quite long time. We also did a left dicksulpike test in this patient. With augmentation. In the left dicksulpike test, after a latency of 2 seconds, you see a upbeating left torsional nystagmus, which is lasting 10 seconds. So then we anti-flex the neck 60 degrees, making it 30 degree above the horizon. And again, you can see a upbeating left torsional positional nystagmus, upper pole of both eyes torsionally beating to the patient's left. When it stopped, we carried out the inversion positioning, that is right lateral recumbent with nose down. These tests were done one after another. And now you don't see any nystagmus in the inversion position. So it is a negative inversion test. So now there are two conditions in this patient. She has got a long arm, left posterior semicircular canalolithiasis, and nystagmus latency 2 seconds with 10-second upbeating left torsional nystagmus during the Diffs Hallpike testing. And the left half Dix Hallpike and augmented left half Dix Hallpike test shows a persistent upbeating left torsional nystagmus lasting more than 60 seconds, which disappears during the inversion positioning. We treated the patient with the left apple maneuver, and the prone pitch and yaw maneuver was done for this patient once. She did not respond. We taught her to do the bascule maneuver, and after 7 days, she returns. A left Dix Hallpike retest is negative. The short latency 10-second upbeating left torsional nystagmus has disappeared. We maintained this position for full 1 minute. 40 seconds here, 1 minute here, and in fact 1 minute and 17 seconds of observation. Augmentation was also done, that is we anti-flex the neck 60 degrees to bring it 30 degrees above the horizon to look for the nystagmus of the left short arm posterior semicircular canalolithiasis. Maintained again for full 1 minute, and this was absent. Patient totally asymptomatic. Patient 8 is a interesting patient, a 59-year-old male. 3 days back, he had severe vertigo while he was supine, and as he had turned to his left side, and he had multiple vomitings. And this would occur every time he would lie down or take little recumbency to either right or left with multiple vomitings. Day 3, he comes to me with sitting up vertigo and severe retropulsion on getting up from sitting. The left Dix Hallpike test during the 1 minute of observation did not elicit any nystagmus. Full 1 minute of observation was done in this patient. So after 1 minute, half Dix Hallpike testing was done. And now you see a upbeating left torsional positional nystagmus. Which is ongoing. We carried out inversion test after 60 seconds of left torsional upbeating positional nystagmus. The inversion positioning, that is right lateral recumbent for nose down, did not elicit any nystagmus. It appears that The patient 3 days back had horizontal semicircular canal BPPV that got autocorrected because we don't remain static. We keep on changing our position. Sometimes we are little recommend, sometimes we are right, little recommend, sometimes we get up, and these natural body positioning while sleeping and getting up, they sometimes lead to autocorrection. However, instead of getting embedded into the utricular macula, it reaches the short arm. Prone pitch and yaw maneuver is being done. 1 minute side to side shaking, the vertex facing the ground, and then static positioning for another 1 minute. The reason I have told in the previous patient. Here the static positioning for 1 minute was again done, and then the patient was uprighted. Left disc sulfide test, retest was done. 1 minute of observation. When the cutoff point of 1 minute is there and we don't see nystagmus, then we anti-flex the neck 60 degrees to make it half disc sulfide position. So during the left half disc sulfide retest, no nystagmus is elicited. Patient absolutely asymptomatic, both the sitting up vertigo as well as the truncal oscillations, they disappeared. Not a single drug was used in this patient. One should give sufficient time in observing the oculomotor responses during the positional test, because you will see surprises if you do it on your own. If your technician is doing and you are just perusing the graphs, you won't get many things, many things will be missed. So summing up the short-arm posterior semicircular canalolithiasis, the core clinical features described by Bela Buki in year 2011, they remains the same. Subjective BPPV, that is the type 2 BPPV, sitting up vertigo, non-positional disequilibrium, no nystagmus during the conventional positional test. We are not talking about the auxiliary tests. There are abnormal diagonal anterior-posterior truncal oscillations during and after sitting up. In year 2022, half disc sulfide test, they showed upbeating ipsitorsional nystagmus of more than 60 seconds with negative inversion test. In many of these patients, upbeating ipsitorsional nystagmus was also elicited on getting them up from the lateralized disc sulfide position or during the augmented half disc sulfide testing in 2024 by the Jisoo Kim paper. In many patients, half disc sulfide test shows upbeating ipsitorsional nystagmus of more than 60 seconds with positive inversion test. That is, these patients have, in addition, posterior semicircular cupulolithiasis of the same side. And again, in these patients, you get upbeating ipsitorsional nystagmus on getting up from the lateralized disc sulfide position. So the oculomotor responses on getting up from the disc sulfide position, they do not distinguish between the two conditions, that is the short-arm posterior semicircular canalolithiasis and the left or right posterior semicircular cupulolithiasis. Many of the patients with typical posterior semicircular canal may have coexisting short-arm posterior semicircular canalolithiasis, or sometimes they get transformed into the each other. So when to suspect short-arm posterior semicircular canalolithiasis? Patients with history of BPPV but no nystagmus during the conventional positional test, yet they have a severe non-positional disequilibrium. Half distal pike test elicits upbeating ipsitorsional positional nystagmus of more than 60 seconds. That is the persistent ipsitorsional positional nystagmus of upbeating type. But inversion test is negative, where the posterior lithiasis is concurrently present, which is frequently associated. Inversion test may be positive. Sitting up from the distal pike test may elicit upbeating ipsitorsional nystagmus in short-arm posterior semicircular canalolithiasis, but this doesn't differentiate it from the posterior lithiasis. No reversal nystagmus on getting up from the distal pike test. Absence of orthotropic nystagmus or the presence of downbeat nystagmus during the position 2 of the Apley maneuver. That is, when the head is rotated from the distal pike position to 90 degrees to the non-involved side. No way to distinguish the long arm from the short arm variant. This is an interesting study by the man who innovated the bow and yaw maneuver. In 171 patients, they first did a distal pike test, which is called a loaded distal pike test. They antiflex the neck before carrying it down to the head hanging position. And then they did a bow and yaw maneuver. And they did a retest distal pike testing. In 68 out of 171, making it around 40% cases, there was no need for the Apley maneuver. They recovered only with the bow and yaw maneuver. The rest 103 patients responded to the Apley maneuver. So from this study, it appears that the cases of short arm posterior semicircular canalolithiasis, they are indistinguishably merged with the patients with long arm posterior semicircular canalolithiasis. So diagnostic maneuvers and repositioning of short arm posterior semicircular canal BPPV. This is the short arm of the horizontal semicircular canal. Posterior cupula is parallel to the Earth's gravity during the distal pike testing. When the half distal pike testing is done, the cupula becomes orthogonal to the Earth's gravity and you get a upbeating ipsidorsal nystagmus. So how it is repositioned back, there the otoconal debris you see in the short arm. When you do a stretch, bow and yaw maneuver or prone pitch and yaw maneuver, the otoconal debris, it shifts towards the utricular macula in the elliptical fossa and gets embedded. So again, we sum up here. Type 2 BPPV, Buki 2021, subjective BPPV, setting up vertigo, non-positional disequilibrium, nose nystagmus during the conventional positional test. Abnormal diagonal anteroposterior truncal oscillations during and after setting up. In year 2022, SCOCO added that there is a upbeating ipsitorsional nystagmus on getting up from distal pike testing, which is of more than 60 seconds with positive or negative inversion test. And in year 2024, the G2 came from South Korea, innovated the augmented left or right half distal pike testing. So in type 2 BPPV, chronic canalolithiasis in the short arm of the posterior semicircular canal results in low-grade deflection of the posterior cupula without generating oculomotor responses during positional test. That is the conventional positional test. Possibly, otogonia may settle on the utricular surface of the posterior cupula and become adherent, explaining the genesis of short arm posterior semicircular canalolithiasis. So the extended spectrum of type 2 BPPV is on. There are overlaps. The typical posterior semicircular canalolithiasis, residual dizziness, it may be because of the type 2 BPPV or short arm posterior semicircular canalolithiasis with all those typical features of Bela-Buki in addition. Or it may coexist with them, as we saw in one of the cases. The type 2 BPPV, that is short arm posterior semicircular canalolithiasis, may get transformed into posterior semicircular cupulolithiasis on the short arm side of the posterior cupula. So how not to miss short arm posterior semicircular canal variant? Look for oculomotor responses after uprighting the patient from the distal pike test. Suspect distal pike test if it elicits more than 60 seconds nystagmus with positive or negative inversion test. Suspect even if the distal pike test elicits upbeating ipsitorsional nystagmus of less than 60 seconds, but if any one of the following is there: absence of reversal nystagmus, absence of orthotropic nystagmus in the position 2 of the apple maneuver, presence of downbeat nystagmus in the position 2 of the apple maneuver, failed apple maneuver perfectly executed in adequate numbers, residual dizziness, augmented half Dixalpike test innovated by Jisoo Kim in 2024 may help. Consider bow and yaw maneuver or our innovation of the adapted prone pitch and yaw maneuver before typical long arm variant in all patients. So this is how the augmented half Dixalpike test is being done. Here, during the right Dixalpike test, you don't see any nystagmus. Ideally, this should be maintained for full 1 minute. I didn't do that I'm showing it here because this patient elicited a very significant nystagmus during the augmentation. After 1 minute, the neck, which is rotated or yawed 45 degrees to the right and is 30 degrees below the horizon, is anti-flexed 60 degrees to make it augmented half Dixalpike test. Here you see right torsional upbeating nystagmus. And if it lasts more than 60 seconds, the next thing you should do is to perform a inversion test, that is in this case left lateral recumbent with nose down. If it disappears, then it is a right-sided short arm posterior semicircular canalolithiasis most probably. And if it changes direction, that is it becomes downbearing and left torsional, it is likely to be cupulolithiasis with or without short arm posterior semicircular canalolithiasis in addition, because two are difficult to differentiate. Treatment options: Bookie's maneuver, repetitive sit-ups from the Dixalpike position, because these truncal oscillations in their series occurred only while getting up from one side, that is they were lateralized. So they did repeated sit-ups from the Dixalpike position 10 times per session for 3 sessions every day for a week. The other is bow and yaw maneuver, which is adapted by us to make it prone pitch and yaw maneuver. Blender of exercises, Pascal maneuver. Thank you very much. I finished my.
Thank you, sir, Dr. Vats, for that wonderful talk. And I think you've given us a lot of information about the posterior semicircular canal. I think I have to rethink some of my diagnosis as well of the patients where when we are unsure. And I think you made it very clear how to differentiate between cupulolithiasis and a short arm. That's one of the big differences that we need to keep in mind. I'm just going to wait for some questions. Dr. Tarak has his hand up. So, would you like to talk?
Yeah. I'm audible?
Yes. Yes, sir.
Tarak sir need to unmute himself.
Yeah.
Balam is also asking something.
Yes, sir, you can unmute yourself, sir.
So yes, a lot of inputs at that. You made the topic very simple, especially what we had difficulty in short-term cupulolithiasis. So short-term canalolithiasis, where the inversion test, whether it has become negative, that's okay. Then it becomes positive. When intermediate, the intermediate is the one thing that is not, we don't get a strong response, but we get still the nystagmus. So these all the things has been very clearly. And already we had seen your discussion on this and maneuver for differentiating these two things. Wonderful, you made it very simple. And is there any anatomical variation that you see in the cupulas, in the posterior canal? Does it matter anything that plays a role?
Yeah, that plays a role because the posterior cupula may have a vertical orientation during the Dix-Alpine testing. So that may not get stimulated at all. So the gravity is parallel to the gravity. To bring it orthogonal to the gravity, we need to do a half Dix-Alpine test. So this is one condition. The other is it may be a vestibulum angulated cupula where you will get upbeating ipsitorsional nystagmus during the Dix-Alpine testing. Dix-Alpine I'm saying about. Or there may be a canal angulated cupula where during the Dix-Alpine testing you may get a nystagmus which is downbeating and contratorsional during the Dix-Alpine testing. So the shape of the cupula, whether it is a neutral cupula, whether it is a canal angulated cupula, and whether it is a vestibulum angulated cupula, will give a different pattern of nystagmus during the Dix-Alpine testing. So the main thing is that if you get a, say for example, during the right Dix-Alpine test, you get a downbeat contratorsional, that is left torsional nystagmus, it should invert in the left lateral recumbent with nose down. It should become upbeating and right torsional. So that is because a cupula has two surfaces. The deflection towards one side is excitatory and deflection towards the other side is inhibitory. So if you rotate the patient 180 degree, that's what Apley told in 2001. And unfortunately, even the Berenice Society does not make any mention of inversion test in their criteria of 2015. So this is very important. But in my series of patients, I have not seen a single patient of posterior cupulolithasis showing downbeating contratorsional nystagmus during the Dix-Alpine or half Dix-Alpine testing, which becomes upbeating and ipsitorsional during the inversion position. So, but this has been reported from lot of the Western literature. It has been reported.
So in the situation of downbeating and contratorsional, how to differentiate this non-Amplerian?
Yes, it becomes very important. Usually, at this point, if the cupula is shaped like that, that it gives a downbeat contratorsional nystagmus during the Dix-Alpine testing, it becomes really difficult to differentiate it from the apogeotropic variant of the posterior semicircular canal BPPV. The only thing is that many patients with the posterior cupulolithasis, they have got the same type of nystagmus. That is, if they have got a right torsional upbeating nystagmus during the half Dix-Alpine testing, it will have similar nystagmus on getting up from the Dix-Alpine position. But here you are talking about the downbeating and contratorsional nystagmus. So usually there is no nystagmus inversion. There is no nystagmus seen as the patients from apogeotropic variant of the posterior semicircular canal BPPV are uprighted from the Dix-Alpine position. So inversion, that is a reversal nystagmus, is not seen in that. So it becomes really difficult in such cases to differentiate between the two. The second is the inversion testing. If the contratorsional downbeat nystagmus is seen in the right Dix-Alpine position, that is, if right Dix-Alpine shows downbeat and right torsion nystagmus, it has to become upbeat and left torsional, right torsional with the nose down to the left. So that is, it confirms the posterior cupulolithasis of the right side with a cupula which is vestibulum angulated. Sorry, canal angulated.
Got it, sir. So there is a chance of even non-Amplerian also getting settled when we are turning the patients, when we are doing inversion. Apogeotropic also, there's a chance that they also may go down. Have a Dix-Alpine which the non-amplary triggers downbeat contratorsional. When we go for an inversion, when you turn it, is there chance of that non-amplary also going to the utricle? So from the non-amplarian. So in those situations, both can get correct.
Yes, it can go correct. In one of my patients, one of my patients with typical posterior semicircular canal BPV got converted to non-ampullary arm, apogeotropic variant. And when the vestibule maneuver and the mastoid oscillations were done, it got converted into the posterior cupulolithiasis. Possibly it went onto the short arm side and got embedded there. But that was a learning case, because in that case I used continuous mastoid oscillations for 1 minute. So what happened that during the inversion position, that is the 45-degree nose down to the non-involved side, when I put the mastoid oscillator, the otoconal debris got disengaged from the jammed position in the non-ampullary region. It went into the utricle, but because of the continuous vibrations, it did not get embedded into the utricular macula. And finally, it reached the short arm side of the cupula and got the adherent to that. So that is the case I reported. And from that time, I always do vibrations, mastoid oscillations for 15 seconds. Then I keep a static head positioning for 1 minute, and then I repeat it for 15 seconds, because mastoid oscillation is like a two-edged sword. If you do it more, there's a chance that you can induce a BPPV by disengaging it from the utricular macula. The otoconia which are embedded in the utricular macula, they may get disengaged.
Thank you, sir. Thank you. Wonderful explanation with the slides. We really enjoyed a lot of new learning, sir. Thank you, sir.
I think we are running short of time. We'll take a couple more questions around. One is that's a good question. How to differentiate an anterior semicircular canalolithiasis from a short-term posterior semicircular canalolithiasis on setting up reversal of direction? Does it really help?
Is this question here?
So it is in the Q&A. They mentioned that. So how can we differentiate the short term and the anterior semicircular canalolithiasis based on the sitting up reversal? Does it help us to differentiate it?
See, most of the patients with anterior canal BPPV, I have not seen any patient of anterior canal BPPV reversing. Secondly, the anterior canal BPPV is extremely rare. The what thing I do is that when I see downbeating nystagmus during the Dix-Hallberg test, or then I do a straight or enhanced straight head hanging test, and then I complete the echo in a mirror then and there only. If it doesn't go away within 1 time, it is for sure that we are not dealing with anterior canal BPPV, because the cupulolithiasis of the anterior semicircular canal BPPV, anterior semicircular canal, is not recognized by the Berenice Society, and there are only 1 report of canal jam in the anterior canal that resulted in the nystagmus which was upbeating. So the partial canal jam is even not reported. So the differentiating between the short arm usually has got a nystagmus, no nystagmus during the Dix-Hallberg testing. There is a upbeating ipsitorsional nystagmus during the half Dix-Hallberg testing, or getting up from the right or left Dix-Hallberg testing. And while the anterior canal BPV will have the downbeat nystagmus and with ipsitorsion.
So one more question they've asked. So you mentioned that during the inversion test, there's usually the disappears, the nystagmus disappears. What happens if there's persistent nystagmus on the half Dix-Hallberg and you do the inversion, but the nystagmus persists but does not reverse? Do you still call it a short arm, or do you call it a cupulolithiasis?
See, if the nystagmus you get in the half Dix-Hallberg test remains same in terms of vectors, directional vectors, both vertical as well as torsional, and it does not reverse in 180-degree transition to the opposite side, it cannot be